himself. And so with that glorious introduction, my name is Nick Rowan. I'm an endoscopic sinus and skull-based surgeon. I'm here with my partner, Dr. Raj Mukherjee. And I'd like to thank Leslie, JD, and the CSRF for having us. It's a privilege to speak to everybody, and looking forward to speaking to you tonight about optimizing post-surgical outcomes in patients with Cushing's. And so I'm gonna go ahead and get started with about a 20-minute overview of things that are related to your nose in endoscopic and nasal surgery. And then I'm gonna hand it over to my partner, who's gonna talk a little bit more kind of broad picture about some quality of life, some broad quality of life measures and Cushing specific outcomes that our group has reported on. And so to get started, I have no disclosures for this talk, and kind of broad objectives about what I want to speak about is, again, kind of goal of our talk is to speak about quality of life in endoscopic pituitary surgery. I will first kind of go over what we know specifically about what happens in the nose and the sinonasal cavity, and how to measure and design some of these quality of life investigations, which I think gives some pretty good insight onto exactly how these kind of outcomes are investigated. I'd then like to submit to you and question the audience and supply some answers. Is there anything that we're missing? Are there things like smell loss, taste loss that happen to our patients who are undergoing these types of procedures? And are there any kind of approach-specific considerations? So are there things that we can do in surgery to make patient outcomes better following their surgery? Finally, I'd like to talk about kind of where we're going, some of the investigations that Raj and I have, and you know, some ways that we could potentially improve outcomes following these types of surgeries. So as a broad disclaimer, I am not going to present to you a lot of Cushing specific information in this talk. I will submit to you anecdotally though, that not all patients with pituitary pathology are the same, and I will be very frank that I have been humbled in the setting of taking care of patients with Cushing's disease. And it's a challenging pathology, especially with regard to the nose. 100% of my practice is focused on managing patients with nasal disorders. And that manifests itself with thousands of patient visits a year, hundreds of nasal surgeries, and patients with Cushing's can be really humbling with the degree of scarring, some of the technical difficulty that they present during surgery. And I think that managing sinonasal symptoms and the healing post-operatively is really of the utmost importance. That's something that I saw in my training and I continue to see in my practice on a daily basis. And it's taught me a lot of tricks and trade along the way. So what do we know about endoscopic and nasal pituitary surgery? Well, we know that there are lots of advantages to this type of approach. Using the endonasal corridor allows two surgeons to be operating at once. And theoretically, and in many cases, it does allow for improved visualization, which in turn may lead to improved surgical outcomes. Patients can have decreased perioperative complications, and in some situations, decreased length of stay. They get out of the hospital faster as compared to some traditional approaches. But what are the disadvantages? You know, we talk a lot about how and why this is so good. This is minimally invasive. But what are some of the disadvantages? Well, I think it's really important to acknowledge that through this little corridor, which is the opening to the sphenoid sinus, which is kind of where all the action happens, you know, when Leslie's commenting about the guys that go in there and get it out. Well, this is the front door to where everything happens during the surgery. That's this is looking within the sphenoid sinus and looking at where the pituitary gland sits. This area in the center of the screen right here is the sella, and right behind that lives the pituitary gland, the carotid artery, the optic nerves, and lots of really important critical neurovascular structures. And a way that I think about this is that although this is a minimally invasive approach, it can be maximally destructive to the endonasal corridor and to the nose itself, and especially in the setting of patients with Cushing's. So I think it's important to keep this tenet in mind. And, you know, as a surgeon and somebody who sees patients routinely postoperatively, this is something that I make sure to focus on. And so what do we know? You know, what has been shown in the literature? What kind of hard facts do we have? Well, we know that there's obvious quality of life implications in the settings of Cushing's, period. There are also issues with patients with larger tumors who can have issues from local compression. They can have visual loss, obviously endocrine abnormalities. And we also know that in many situations, patients present to me with normal noses. However, postoperatively, their nose may look like this. And if you haven't ever seen the inside of a nose, it doesn't much matter, because you can probably guess there's not much air that's moving through that nose. That's a gigantic booger, a bunch of mucus caught in somebody's nose postoperatively. And so there's lots of implications of using the nose, which can lead to nasal crusting, it can lead to nasal blockage, drainage, it can lead to holes in the nose, especially in the setting of a challenging operation where we're dealing with very difficult mucosa, very delicate mucosa. We know that patients can have long-standing issues with both smell and perhaps even perceived taste postoperatively. They can have problems with recurrent infections. They can have mucoceles. And sometimes even in the settings of really big or revision surgeries, they can have cosmetic deformities or changes to the outside of their face. So why do we measure quality of life? Well, really, quality of life, it's increasingly a measure of surgical success rather than, the typical kind of macho surgeon outcome saying, yeah, we got it all, we did great, patting ourselves on the back. It's an additional outcome measure that really sticks with patients postoperatively, and it influences their daily lives. And it's a lot more important as to whether they had a CSF leak at the time of surgery. That heals. Some of these other disruptions are long-standing, and they can have significant implications on your life afterwards. And although again, many of these pituitary pathologies are, I'm air quoting here, benign. There's broad implications to the structures that surround these pathologies in the pituitary gland. And we really need to take some of our surgical goals, and speaking for the two of us, we do take these into account when managing patients and their variety of pathologies in the pituitary gland. So how do we assess quality of life? I think this is really important, and I suspect that most everybody listening to this does know that quality of life is not assessed by surgeons. It's not assessed by the doctors. We're all biased. We have implicit biases. It needs to be captured from patients. And this is done using validated metrics. So these are questionnaires that are specifically designed to measure quality of life impact. There are many different ways to do this. So you can ask very broadly quality of life related questions, or you can get very specific. So you can ask, for instance, I have all my patients fill out a questionnaire that exclusively asks patients about their ability to smell. And so we also ask questions about their daily functioning, how they get on with their daily lives, their energy levels, and the like, and kind of everywhere in between. So again, there's many quality of life assessments available, but I'm a sinus surgeon and a rhinologist. So the questionnaire that we've used the most commonly over the past 20 years or so is something called the SNOT 22. We all like to be a little bit cheeky, and the sinonasal outcome test is really a mainstay of something that I use in my clinical practice. And though we're all giggling a little bit, it is something that it has really a tremendous degree of clinical relevance to me. And what it does, the SNOT 22, is it's a nice questionnaire that has really kind of comprehensively assesses all of the symptoms that relate to your nose. And we use it kind of broadly across the field. So it allows us to speak in a similar language, both as surgeons and sometimes even as patients. We can track these scores over time. And so we published a paper on this a couple of years ago, looking at all patients who underwent endoscopic skull-base surgery, mostly patients with pituitary tumors. And what we saw was that over time, as the time goes on, as you go from left to right, symptoms they all went up about the first month afterwards. You can see that the score going up, but over time, they generally decrease. What was really interesting was that patients on the gray line, the gray dotted line, patients who were symptomatic preoperatively, who presented with nasal blockage, decreased sense of smell, sinus infection, that kind of stuff, they actually did better over the long haul, which was really interesting. So they actually improve from their sinus surgery perspective. And so temporary worsening sinonasal quality of life at 1 month postoperatively makes a lot of sense because, again, the nose kind of looks like this. It's blocked up. You can't breathe. You can't smell. You have lots of drainage coming out. You have crusting. It's uncomfortable. And so their quality of life decreases. However, we do hope that their noses heal quite nicely and they look nice and pink after a long period of time. And sometimes, as many of you who are on this call know, that it does take a bit of time, a bit of work to improve that over time. But this is kind of what we're shooting for: a nice, healthy, pink cavity in the back of the nose that is doing what it's supposed to do. There may be some scar bands associated with it, but it doesn't have a collection of mucus and crusting and or infection back there. And so the SNOT-22, it was never actually validated in patients with pituitary surgery. And so just this past July was the first time we actually had validation of this metric. However, the authors of this paper make a really insightful point that perhaps not all parts of that SNOT-22 questionnaire, of all 22 questions, weren't necessarily that relevant for patients with pituitary pathologies. And so using other instruments might be a better idea. And so there's some shortcomings of this questionnaire, and it doesn't account for all of the things like visual issues, many of the endocrine issues that Cushing's patients by definition have, some of the intracranial pathologies that patients can have, or things like radiation or other medical therapies that patients may have postoperatively, how that impacts patient quality of life. And so I think it's really important that when using quality of life instruments that we consider all of these other things that I've spoken about over the past few minutes here, and really kind of comprehensively evaluate patients. And so there's several tools do exist. We wrote about this and performed a systematic review and published this in a journal called IFAR, the International Forum of Allergy and Rhinology. And there's 5 really endoscopic endonasal skull-based surgery-specific instruments, and the 2 that are the most really useful in our armamentarium of tools are the skull-based inventory and the Ask Nasal 12. The skull-based inventory is a very nice kind of comprehensive instrument that captures all different aspects of quality of life, whereas the Ask Nasal 12 is a very short 12-item index that can be done. It says 2 minutes here. It takes patients about 2 minutes. Many of my patients, when they're coming back for follow-up, they can answer it. I watch them do it, and it takes anywhere from 30 to 45 seconds. And immediately, just from reading that, I can have good insight into how they're healing and where they are in the recovery process. But beyond these questionnaires, is there anything else that we're missing? So I personally, again, I am biased, and I have my own interest, and I not only do I like using my nose, but I like my patients to be able to use their nose. The importance of olfaction and the sense of smell really can't be overstated. From the psychosocial implications from eating or smelling mom's turkey in the oven on Thanksgiving, or perhaps even smelling smoke from a fire. Having a patient smell and having them taste or experience flavor, it's really important. And we've seen this in broad population level data that the sense of smell actually has its own implications on quality of life and productivity and even cognitive function. We know that it's really, really important. We don't understand it fully yet, but we know that our pituitary patients really would benefit from having a continued, functioning sense of smell postoperatively. When it comes down to it, the degree of olfactory loss or smell loss that patients experience postoperatively is likely related to how much, yours truly and my neurosurgical partner manipulate that area. So if it gets injured during surgery, like anything, the sense of smell may not work as well afterwards. And so there are certain methods that you can take to improve this area, to improve the healing and minimize the trauma to this area that I'll mention in a couple of moments here. And so, sometimes we do have pathology that directly involves these structures that it's unavoidable. However, in most Cushing's patients, we are able to physically avoid this area because the olfactory nerves themselves are not necessarily involved by the growth. And so, as it turns out, most studies that do investigate this are kind of ill-equipped to really tell us on a broad level how the sense of smell works afterwards. Usually it's a very basic question that asks patients a yes, no, does your sense of smell work, which really isn't super helpful when doing a more detailed dive into smell and taste. And so this is just a slide to show the high heterogeneity and the substantial variation that occurs across the different published studies. And my hope is that either myself and my partner investigate this in the future, or somebody, we can team up with some other institutions across the country to really make sure that we are achieving the best smell and taste related outcomes in our patients post-operatively. And this is something that we've been thinking about for a while. So when you're physically in the operating room, if you look on the right side of this picture, I think I have an arrow for it. There is that little grain of rice, that little hole that I was pointing to before in that first slide. That's the opening to the sphenoid sinus. All of the mucosa above that has the olfactory epithelium in it, which is the olfactory nerve fibers are inserted there. So my goal sometimes during surgery is keeping the neurosurgeon away from the area to make sure that everybody can smell and taste post-operatively. And so we know that if we make an incision to specifically go out of our way to save this area, the patients actually do quite well with their sense of smell afterwards. And you can diminish olfactory loss afterwards if you do protect that area. We also noticed, though, first anecdotally, and then we backed it up with some literature, that patients actually report disruptions in their ability to taste that are distinct from their ability to smell. And so we were very intrigued by this, by a publication out from the Cornell group many years previously. We investigated our own population. What we found was that patients actually distinctly say that their sense of smell and their sense of taste are isolated and recover over a different period of time from the broad sinonasal symptoms that patients experience. So the nasal crusting, the nasal blockage, the drainage, all those things improve, but it does appear that sense of smell and sense of taste, patient-reported sense of smell and sense of taste, does kind of lag behind over time. This is just another self-reported question. So it's not something that is, it's not tested. It's like sometimes we as humans are a little bit unreliable. And so this does need to be backed up by objective testing. It's like saying that your blood pressure is high. You got to really put that blood pressure cuff on your arm to know that that loss is real. My suspicion is that sense of taste really isn't impaired too much. However, their perception of food and flavors really can be thrown off when the nose isn't working, when the sense of smell isn't working. And so a couple of touching up points here. Another way to make sure that the nose heals well afterwards, and a question that Dr. Mukherjee and I had is, can we better protect the sinonasal mucosa and the structures better as we're doing these approaches and as we're taking out these tumors through the nose? Again, these approaches are great, but how can we minimize the maximal destruction of these approaches? And hopefully coming to a scientific journal to you soon, we'll be able to report back on our experience using a endonasal protective device to limit the amount of trauma into the nose. So this is on the left side of the screen. This is a picture of a device that was placed in somebody's nose, and it actually allows us to protect that corridor. So rather than that last picture that I showed you where we're looking right at the olfactory mucosa, it's actually protected here. This theoretically can decrease the amount of manipulation and irritation to the area where the smell nerves live. It can minimize scarring afterwards, and frankly, the amount of time that we spend in the operating room as it can improve visualization. We also have some other additional question as to whether we can repair the sites where things like nasal septal flaps are created. So we use lots of grafts to reconstruct skull-base defects. Why can't we use grafts to help the nose kind of heal better afterwards? And so many of the techniques that we do, they do cause trauma, and we have some ongoing thoughts and potential investigations about having these areas heal afterwards. Near and dear to my heart, again, is the treatment of smell loss. It's been certainly very relevant during the ongoing COVID-19 pandemic, when this small virus problem that we're all unfortunately dealing with does cause a loss of sense of smell. And our Cushing's patients are no different. There was a really nice study done by a collaborative effort between Stanford and Emory several years back, where they did a very kind of simple, low-risk intervention of giving patients omega-3 fatty acids afterwards, omega-3 supplementation. The patient's sense of smell actually improved. This study is not kind of a panacea. It's not a be-all, end-all. I think there's even the authors would agree that there's some room for improvement in their findings, and the further investigation is warranted. But certainly, it's an exciting, a very, very exciting trial that they propose. And so, as part of a summary for my portion of things, quality life in endoscopic and anal skull-based surgery, it's really important. It's important because it's a measure of surgical success. It actually allows us to help in our own decision-making process. And I think it's something that we probably don't look at enough when we talk about these tumors. And, we have our patients, just like people who are on this call and listening in the future, that, you are telling us, and measuring quality of life is really important so we can more objectively study this and we can report it back, speak about it, and quite frankly, just make it better. We need consistency across different studies. We need to be able to speak so that Raj and I, we have a common language where we can say, hey, a person's SNOT 22 score is 110. That's as bad as it can get. But we need to all be reporting the same quality of life instruments and keeping this the same across different studies. Many of these studies we have tried here at Johns Hopkins and will continue to do so in the future to leverage our collaborative network and seek out assistance from your group and others to make sure that we all continue to work together so that we have the appropriate voices of the surgeons, the medical doctors, and most importantly, our patients in figuring out how to make these outcomes better. And so we need to be thoughtful about this. And so I'd love to turn the floor over to my beloved colleague, Raj. Take it away, bud.
Thanks so much, Nick. Let's see. So I'll try to share my screen here. And so first, I'd also like to thank Leslie, JD, and the CSRF for the opportunity to talk with you all. I think, I'd like to supplement and add to what Nick discussed. And I think in terms of context, Cushing's disease and Cushing syndrome, it's not that old of a diagnosis. We're just about 100 years or so past when Harvey Cushing, who was here at Johns Hopkins, sort of defined the disease. And the reason it is, the namesake disease of his storied career is because it was so difficult to treat. It was so difficult to diagnose. It was so difficult to treat. There was such a high proportion of recurrence, such a low proportion of cure. And so, even in modern times, again, it hasn't been that long since the first surgical treatment of Cushing's disease. We're making incremental improvements, but it is a challenging diagnosis for patients to deal with. It's a challenging diagnosis for us as surgeons. And as we move along in an iterative process, our hope is to really be collaborative and to be thoughtful, as Nick mentioned, to try to make things better for folks that are dealing with this disease, both upfront and for folks that have residual tumors and upon recurrence. So with that, I wanted to go through a couple pieces of information, maybe over the next 15, 20 minutes or so, that'll hopefully set up our questions. And I think some of the points that we're going to be bringing up in the question and answer session will hopefully be addressed here. But I thought it might be interesting to discuss a few points about a brief history of our approach, of our endoscopic and nasal approach, because you can go back thousands of years, and there are hints of the approach that Dr. Rowan and I use day to day. And there has been, especially in more recent past, a move towards these minimally invasive, more tailored approaches. And then I'd like to talk a little bit about how we as a field are moving more from just describing outcomes to truly predicting quality as focused on the patients. And in particular, a lot of you on the call tonight may have participated in a survey from CSRF last year. And I wanted to go through some of those results. One, because I think it's interesting. Two, it provides some insight into what folks are going through. And three, it may actually be helpful to know that you're not alone, that a lot of folks are going through, a lot of symptoms and a lot of issues that are multifactorial as they're dealing with their Cushing's disease. So, if you look back in antiquity, for hundreds of thousands of years, for as long as we have existed as humans, and even in the pre-human period, tumors have impacted the skull base, including the pituitary region. And you can see this even in the Steinham skull, which is one of the earliest pre-Neanderthal humanoid skulls in existence. If you look back at ancient Egypt, they would go through the nose for the mummification process. Now, this is exactly what we don't want to do in actual surgery, going up into the brain, but using the nasal corridor is a great way to get into the skull base. And you can see right here, this is the cella. This is right where the pituitary gland sits. In more modern times, Victor Horsley was the father of European neurosurgery, and his approach to pituitary adenomas, including Cushing's, was through this giant bicoronal incision. So you can see this is the patient's head that's been splayed open. You can see the right frontal lobe here, the left frontal lobe here, the optic nerves. The pituitary gland would be sitting here, but truly a wide skull-based approach with, you can imagine, a lot of cognitive impacts and a lot of surgical morbidity. Around the same time, both in Europe, in Austria, as well as in the United States with Harvey Cushing, there were more minimally invasive approaches that were taken. And these were approaches done by Hirsch and otolaryngologists like Dr. Rowan, as well as Dr. Cushing, a neurosurgeon like me. Some of these more minimally invasive approaches were abandoned after some time, just because, honestly, the technical limitations like illumination just didn't exist at that time as they do today. But over more modern times, and especially over the last 10 years or so, we've seen a real resurgence of interest in these endoscopic and nasal approaches and using a team-based approach. So this is a paper that Nick and I published in Pituitary a couple of years ago that looked at some of those trends in an academic setting in folks that have been in practice for quite a long period of time. The majority were in practice for over 20 years, and they at least performed about 50 cases or more per year. So at least one endoscopic and nasal approach, per week. Which is the general threshold for being a high volume surgical practice. And what we found in that survey, again, of these super subspecialized surgeons, was that over time, from 2010 to 2020, the majority of these surgeons ended up doing team-based surgery, transitioned towards team-based surgery. The vast majority used an endoscope, which is, what Dr. Rowan was discussing, an endoscopic and a nasal approach. And they used that endonasal corridor, as opposed to, older, corridors that were used in older times, including the sublabial approach, which is really, deep to the gums, or in the gums and under the upper lip. So this endoscopic and a nasal approach in a team-based fashion is really the standard bearer in the modern era. Historically, when we looked at our outcomes for pituitary adenoma patients, it was done using, standard metrics, not really patient-focused. And this is an example of that paper from about a decade ago, from here at Johns Hopkins, including myself, back when I was a postdoc. And what we looked at was a big data set. It was a big national data set of about 8,000 patients, specifically elderly patients that underwent endoscopic and a nasal approach for pituitary adenoma resection. And what we found was, a relatively high complication rate. About 1 in 3 patients had some inpatient complication after their surgery, and there's a non-insignificant mortality rate, greater than 3% mortality rate in these patients. And so, historically, when we tell people, oh, you're just going to have a pituitary surgery, you'll be in and out in a couple days, that might be true for the majority, but I think data like this has historically been really important so that we can provide, more details to patients and to be more thoughtful in our full assessments. Part of that next iteration is not just describing the incidence, the number of complications, and the number of issues, but trying to be predictive of those patients and trying to identify those patients that are going to be most at risk. And so historically, that was done through really large indices like the Charlson Comorbidity Index, where you would take all of these different diagnoses that a patient may have and try to put in some kind of algorithm to risk stratify them. But practically speaking, no one has time to go through this giant list with patients. And so a lot of our effort in the more recent past has been trying to hone this list down into the things that are most relevant. And we've been using more recently what they call the MFI-5, or the Modified Frailty Index 5, that looks at a patient's functional status, diabetes, COPD, congestive heart failure, and hypertension as a real measure of getting a sense of who's at risk of having a poor complication after surgery. And we published this again a couple of years ago in Pituitary, and what we particularly found was the Cushing's disease group had significantly more comorbidities, which are going to be in these gray lines, as opposed to patients, say, with prolactinomas or non-functional adenomas, where that group had, in the dark line, the majority of those patients just didn't have any comorbidities at all. So, what that tells us, almost implicitly, we know this, that folks with Cushing's disease, have more medical issues. And so that places them at a higher higher rate of having a higher MFI-5 score. And we were able to determine specifically, if you have an MFI-5 score of 2 or higher, you're at significantly higher rate of having complications, greater length of stay, greater readmissions. And so it's allowed us to really hone in on Cushing's patients specifically, and the subset of Cushing's patients that have more than 2 comorbidities as those that we can provide some extra guidance to, some prehabilitation on, try to modify their modifiable risk factors, including better diabetes control and the like. Moving one step further, as Nick was referring to, being focused on quality of life is such an important part of the disease process. It's not just trying to make a picture look good, and it's not just survival, but it's trying to allow you to have a meaningful quality of life. And so I think over the last 20 years or so, you've seen in the pituitary literature and in the Cushing's literature an increasing interest and focus on studying quality of life. And I'd like to spend this last little bit going through some data points that I think hopefully will be of interest. Amongst all the quality of life tools that we have available to us, I think some of those that you may see as a Cushing's patient that'll increasingly come up as you go to see your doctors will be a general quality of life instrument, something like the SF-20. It's a 20-point instrument that gives us a sense about how you're feeling in general in life. And then something that's a little bit more tumor specific. And there's the 2 most prominent quality of life instruments for Cushing's patients are called the Cushing Qual and the Tumingen 25. And so here at Hopkins, we're going to be trying to get a sense of which of those instruments and which of the items on those instruments are actually most relevant to patients, because it does honestly take quite a while to go through all of these quality of life instruments. And our hope is in the next handful of years moving forward, we'll be able to come together with a quick assessment, kind of like that SNOT 22, that'll give us a quick assessment of how you're feeling and what's most relevant to you, so that we can help direct your care in the most precise way moving forward. I think Cushing's disease patients do overlap to some degree with other types of patients with pituitary adenomas, including non-functional adenomas, which often present with headaches or vision symptoms, acromegaly, which can cause a lot of joint pain, muscle pain, and some physical symptoms that are, that can be concerning to patients. Cushing's disease is unique in some ways in that the patients are often younger. They have a shorter duration of remission, maybe not cure, but remission. And they often have to progress to more aggressive treatments if they aren't able to have a full surgical resection, or if they're not able to tolerate medical management, and that can include even removal of the adrenal glands. There are some overlaps in terms of concerns about hypopituitarism or needing to be on hormone replacement therapy, and having just negative perceptions about one's illness and sometimes appearance. But there are things that are very unique to Cushing's disease, and that's what I'd like to talk about in the next handful of slides. One thing that is unique about Cushing's patients is can maybe be seen best in the spider plot. So what the spider plot is demonstrating the quality of life in the general population relative to folks in certain disease types. And so to be 100% in this spider plot means that you're doing, you're doing perfect in terms of physical functioning, mental health, emotional health, social functioning, etc. Now, on average, the gray line represents where, the average citizen, the average, person sits. So not perfect, but doing pretty well, generally hovering around that 80% line. For patients with non-functional pituitary adenomas, macroadenomas, non-Cushing's patients, before surgery, they hover around this 40% mark. And that may be due to headaches, that might be due to vision issues. And what you can see is that relative to before surgery, which is this sort of area, this circular area, after surgery, they basically normalize to what one would expect for the average population. So what that tells us is that after surgery for non-functional adenomas, you have a significant and large improvement in quality of life. And ideally, that's what we want to see for all patients. Now, in contrast, when we look at patients treated with Cushing's, we still have this gray line here that represents the general population. But the inner circle or the inner dots here represent someone, when they're initially diagnosed with Cushing's disease. So they're about 20% in terms of their overall quality of life. And they do have some improvement, somewhere between, up to 40, 50% or so, depending on the domain of interest, whether it's pain, general health, vitality, et cetera. But it's nowhere near what the general population is, and that's even after treatment. And that's in this study, it was sort of all comers. It was including those that had surgery, some that had radiation, some that had medical management. And so, what that tells me is when you compare these spider plots, significantly different for Cushing's even after treatment. So it really is a lifelong issue. It's a lifelong disease process that we're trying our best to mitigate and moderate. The last set of slides here are really going to focus on data that many of you have provided. And so last year, in concert with Leslie, we actually surveyed close to 200 folks who are members of CSRF, and we wanted to get a sense of how they were feeling and where they were in their disease process. And so, so what you can see is, folks were generally in sort of that middle age group, which I'm closely approaching now, closer than I would have thought. But 50, many folks were in their 40s to 60s. A vast majority were female. A large proportion had pituitary adenomas and pituitary tumors, as opposed to Cushing's syndrome, which was impacting the adrenal glands or from elsewhere in the body. One of the questions before we came on was related to how a person might do 10 years out. And so, while we had some folks that responded with a diagnosis that was more than 10 years old, the majority of patients did not have data that far out. Most folks had one surgery, although there was a notable proportion that had more than two, and the vast majority did not have radiation. And so that was just to give some demographics and background. Now, there were several domains that came up as interest amongst respondents, and I wanted to point out a couple things. So what you can see is in this first column, when it comes to physical impact, the majority, in almost all of these cases, the majority had a significant physical impact. So loss of physical strength, they experienced pain, decreased sex drive, loss of hair, dental problems. And when it comes to addressing a question that came up many times, many people were wondering, will my adrenal insufficiency get recovered? And in these patients, again, even many years out, close to half had persistent adrenal insufficiency. There's a large cognitive component to Cushing's disease, including memory issues, anxiety, and depression. And a lot of that relates to the broad impact that cortisol, that's steroids, have in managing our memory and our cognition. It's a really complex system, and we don't know all the details, but we do know that cortisol plays a really important role in terms of baseline memory, attentiveness, and mood. There are impacts on energy and sleep, with the vast majority feeling insomnia, feeling lack of motivation, and the like. One interesting finding was that the majority of patients actually felt that their relationships got stronger during their disease process. So even though they felt that having that diagnosis of Cushing's was a lonely process and often caused depression and anxiety, there was something about being on that longitudinal journey that actually seemed to somehow strengthen their relationship. So amongst all this bad news that I showed on the slide before, there is at least a glimmer of hope. In terms of things that people experience during their treatment and their hopes for the future, almost every respondent said that they wish their primary care providers had done more and would continue to do more in terms of diagnosis and ongoing treatment of Cushing's. And I think a lot of that relates to the complexity of of the management, the multidisciplinary management that's necessary. There's not necessarily one provider that will give you all the answers. And so having a primary care provider who is informed and engaged can really be that conduit to get all of those different providers, whether it's a surgeon, an endocrinologist, or others, a psychiatrist and others on the same page, and hopefully optimizing, your quality of life. When it comes to treatment experiences, I think there were a large proportion of patients were just hoping to connect with others and share their experiences, to sort of feel a sense of community and feel a sense of understanding. And I think it's one of the great things about CSRF, and that it provides that community and that platform for folks going through this to connect. When it comes to some specific services, I think this just reiterates some of those particular areas that primary care providers, for instance, pill boxes and journaling, speaking to therapists and speaking to others, including like in a support group. There was a significant wish by a lot of the respondents to have more of those services. We tried to, lastly, break down if there were any predictors of those who felt this way in particular. And what we found was, based on number of surgeries, time from diagnosis, and patient age, those were different groups that had slightly different wants and needs. And so it seemed that the cohort of patients that had 2 or more surgeries were those that seemed to have permanent adrenal insufficiency. And it sort of makes sense. There's a lot of scarring that can happen in between a first and second surgery, and that can increase the odds of having to be on hydrocortisone or diabetes insipidus, long term. That can happen with a first-time surgery as well, but it seems particularly for 2 or more surgeries, at least from the patient perspective, that seemed to really be the threshold. In terms of mental health issues, particularly patients that have been dealing with Cushing's disease for a decade or more seem to be the highest risk. And again, more than 80% here actually had suicidal thoughts. And so it really just underlies the multimodal nature of Cushing's disease on a person's quality of life and even mental health. And in particular, the younger cohort, folks who were in their mid-40s or early or younger, were more worried about the impact of the diagnosis on their marriage, on their relationships, and on their children. And this just sort of reiterates the same, some of the same points we discussed earlier. I think there was a consistent wish to have a support group sort of during recovery, particularly amongst those patients that had multiple surgeries and amongst those that had radiation. So, historically, what we've looked at as surgeons is trying to make the picture look good. So this is a patient that Dr. Rowan and I operated on that had Cushing's, that we, saw this lesion on. Luckily, wasn't invading the cavernous sinus or the carotids, and we were able to have a good resection and what we call remission. We don't really use the term cure, but we use remission, and so that was a great outcome. But there are those that don't have that, and even amongst people that we've operated on. And so, we want to be really thoughtful about what that person's quality of life is going to be, how to maximize it. And I think, again, with CSRF and with your collaboration, hopefully we can be more thoughtful. Hopefully we can be more understanding. Hopefully we can get folks to have, to move these, to move along this spider plot closer to the, closer to what their quality of life was before. That would be a wonderful outcome. Again, we're 100 years into this, and our hope is to make our contribution in such a way so that over these coming decades, we can meaningfully change care and in a positive direction for all of you and for all of those in the future. So we really like to just, again, thank everyone for the opportunity to connect. This is a portion of our multidisciplinary team, including the neurosurgery department, the sinus department, or the sinus division within the otolaryngology department, our endocrinologists here at Johns Hopkins, and we also work really closely with our neuro-ophthalmologists and radiation doctors. It is a multidisciplinary team. It's a complex condition. And we're just really grateful for the opportunity to collaborate and connect with you all. So thank you again for your time, and we're happy to take questions.